So this morning, I was so impressed with the slide that you showed of the regular PET CT scan compared to the other one. And just not knowing that you might have lesions that are just not showing up on your PET scan is a little alarming from a myeloma patient perspective. But I know the role of imaging is really important in diagnosing and at relapse. So do you want to talk about how you use all the markers, the bone marrow and the blood samples and imaging to do an accurate diagnosis, and then at relapse, how that works? And I'd like to see PET scans get better after seeing that slide.
The question is what type of workup to do at the initial diagnosis
And
for follow-up
and at relapse. Yeah.
or if there's relapse. Yeah, so for the newly diagnosed workup should include a bone marrow biopsy and an aspirate. The biopsy would be used to send for immunohistochemistry to evaluate the bone marrow to make sure that there are normal cells also in the bone marrow, the hematopoiesis. The bone marrow is the site where all the blood in the body is being made. And also see what the infiltration of plasma cells look like and count the cells. That's standard of care. The aspirate is being used for multiple things. One is called immunophenotyping. It's also called flow cytometry. It means the same thing. Send a little bit of that aspirate, run it in a machine, and is labeled with flow cytometry antibodies. There are many antibodies we talk about. We talk about treatment antibodies or imaging antibodies, and now I'm talking about flow cytometry antibodies. There's different types of antibodies, but the machine includes a lot of antibodies for the purpose of workup, and that allows characterization of the cells to see that these really are myeloma cells and to look at the different features of these cells. Also, part of the aspirates being used typically for FISH testing, and either it could be used for karyotyping or something called SNP array. All these types of tests are meant to characterize the disease from a prognostic point of view. I mentioned before when I gave my talk that these are quite old technologies, the FISH, the karyotyping. They are probably from the 1980s and they're still being used. And I'm actually not sure why we still do them, just because we did them last week, probably. It needs to be updated. The SNP array is the newer of the tests. It will not capture the translocations. So if you have to run these tests, if I were to choose, I would say, okay, let's do SNP array and FISH testing. But also knowing that you could do sequencing of the samples. That will be done in the coming future. That's not yet standard of care. You can also send off part of that aspirate from the baseline to identify the VDJ sequence if you want to use that to track for MRD going forward. You need to know what the individual patient's signature looks like. So if you don't send that off, you cannot check for MRD with sequencing later. The typical blood work would include a CBC, which is white cells, red cells, and platelets, and a differential, and also a chem panel that would cover the kidney, the liver function, the electrolytes. It should also include a beta-2 microglobulin, albumin, LDH, and standard chem markers. And then, because this is for myeloma workup, you would have to send an SPEP or serum protein electrophoresis, an immunofixation, serum-free kappa, serum-free lambda, and you also want to run immunoglobulin G, A, and M as a default. When it comes to imaging, the standard of care is to do either a whole body PET CT, or it could be something called a low dose CT, which is the same as a PET CT minus the PET tracer. Some institutions like to do it that way. I personally like PET CT because it also can identify potential disease outside the skeleton. The alternative would be to do a whole body MRI. If that's done, it should be done without contrast, because contrast could impact the kidneys, and you don't want that to happen in a myeloma patient. You should not do a skeletal survey. That used to be standard of care. The insurance companies like that because it's much cheaper, but it's about 30 times less sensitive than PET CT. I used to, when I was at Sloan Kettering, to be a member of the NCCN guideline committee for myeloma. And because there were so many insurance companies that were fighting with all the centers, we put in writing in the guidelines that skeletal survey shall not be done unless there is a particular indication. So that should not be a problem for doctors to get approved a PET CT or a whole body MRI. Should be fine. We wrote that in the guideline. They're still trying to say, the insurance companies, oh, you should do X-ray. That's not right. So biopsy, blood work, and imaging for newly diagnosed. For a patient that's being treated and complete the therapy, you could do a biopsy and see if there are residual cells. You could match the MRD sample to that baseline sample if you do sequencing. If you have a sophisticated flow cytometry lab, they could run a flow cytometry MRD assay, but many of the flow labs don't do exactly what it says in the book. So they call it MRD negative, but it's just not the same sensitivity. Instead of ruling out one cell in 100,000, they only rule out one cell in 10,000 or something like that. So that's not MRD negative. But flow could be done even if there is no baseline sample for MRD purposes. Blood work should be done every month to check for the proteins, the monoclonal proteins, and the light chains. That would be standard of care. Then you ask Jenny to talk about the relapse setting. If a patient comes and has relapse, I think these days 95% of patients that relapse is the doctor that says it's relapse. It's not the patient. The patient feels great. The doctor says, I think there is a protein, it's relapse. So relapse sounds like a scary word, but it's usually a protein. And I'm sure you all know what I'm talking about here. Many of you know what I'm talking about. So relapse many times is the protein. So what does the textbook really say? So someone who has zero protein, zero protein, zero protein, if that protein is 0.1, is that really relapse? So the textbook would say that on a clinical trial, it has to go from the lowest point to 0.5 grams per deciliter above that low point. So if it was 0.5 would be the number. So what about 0.1 and 0.2? Formally, that would not be relapse on a clinical trial. But I think as we have learned more, we talked about MRD testing. If you see that it goes from 0 to 0.1 to 0.2 to 0.3, that is the beginning of a relapse. Now, the guideline, the textbook does not say when you have to start therapy. It doesn't say what else you have to do. Do you have to wait for it to go over 0.5? Do you have to wait for it to go 1.0? What do you have to wait for? There is no guideline for this either. It's a judgment call. I think it used to be before that doctors were waiting for it to go over 0.5 up to 1.0. And if all the labs were fine, the patient felt fine, that they didn't change the therapy. But I think there's a drift towards changing the therapy sooner. I want to hear what Dico and Elizabeth says about it. The basic workup for this setting would not always mandate a biopsy. It would not always mandate a PET CT or any other imaging either. Many times the treatment is changed just based on blood work. But I think depending on the situation, sometimes we do biopsies and PET CT, but if it's just a small change, we may change the therapy without doing it. So, but I want to hear what Elizabeth and Dico think about that.
Thank you. I agree. I mean, I think there's like sort of three categories, at least in my clinic. One is when patients have progression, which is obvious. So the numbers go up, which is the biochemical or the protein that you were alluding to, and maybe patients don't feel as well anymore. And then you may, if you got, workup with imaging or whatever, see, the CRAB criteria get worse, and things like that. I think that's obvious. Most of us, I think, would change therapy for the most part in those situations. And then I think there are ones where the patient's feeling great ever starting that therapy, and then you have like a blip that you weren't expecting on the proteins, as Dr. Langren. I think those are like challenging cases, and I think I've gone both ways, and I think I have a real spend some time discussing with the patient what the right thing to do, especially with some of the newer therapies. And as many of you know, there's this phenomenon even called like pseudo progression in solid tumors, and then it's just a lab value. Maybe the lab, something was off in the lab that day. I mean, there can be so many different variables. So if the patient feels really well, otherwise, I may actually try another cycle, just depending on the whole full clinical context of the patient. And then I think there's the sort of the numbers go up, and actually the patient just doesn't feel like him or herself. It doesn't feel well, but there's nothing objective, like, there isn't like a new bone fracture or anything. I think in many of those cases, then, we say the numbers are going up and the patient's just not feeling well, regardless of whether it's the myeloma or the toxicity from the therapy, it's time to change.
Yeah, I think that we don't wait as long as people used to wait, mainly because we have better therapies now. So before, people would, physicians would wait maybe a longer time to start the new therapy because there were no other therapies, or the other therapies were not that great and they didn't have a very good chance of response. And now we have really good therapies. So as soon as patients have what we call measurable disease, especially for some of these new trials, we try to put them on the trials. And one of the issues that we have with patients at relapse is that some patients, they stop making the paraprotein. They don't even make light chains anymore. And so then the patients have pain, and then you do a scan, and then you find something, and then that may be the only place where they have disease is not even in the bone marrow anymore. They don't know making any protein, and you don't see that in the blood. So those patients you have to follow with like PET-CT or MRI or something. You cannot follow them with the blood work alone. And so, that's a whole other array of things, because a lot of those patients are not eligible for trials. So yeah, that's like maybe, I don't know, I would say 10% of patients or something like that you really cannot follow their blood work to see what you need to do. And in most of the times, the best thing to do for those patients are the whole body MRI, or I preferentially prefer the PET-CT too, but yeah, that was my last thing.
Mhm. Kind of along those lines, can you, I have two main questions. You earlier talked about high-risk disease and that high-risk disease still remains a challenge. What are the best types of therapies that you're seeing now for high-risk, newly diagnosed high-risk disease, or even relapsed refractory high-risk disease? And then my follow-up question will be about personalized medicine, how we get closer to that.
We talked about high-risk disease.
It wasn't me, but I can start. So we looked at our own patients with high risk disease, multiple myeloma at MD Anderson, and we had maybe about, I would say maybe 30 patients out of a cohort of 100 and something. So about 15 to 25% of patients have that. And what we saw is that it didn't matter what we did. So those patients were treated with carfilzomib, lenalidomide, dexamethasone, most of them, transplant, and then they continued that maintenance. They continued carfilzomib, lenalidomide, and dex maintenance, and they still relapsed. So even though we did all that, we didn't stop treatment or anything. So I think that what we have to do is move all these new treatments really soon to high-risk disease. And this is happening already. It's happening in the Southwest Oncology Group, SWOG. We're part of SWOG. And so we're trying to do trials through SWOG where we can incorporate, for example, some of the new BiTEs, the bispecifics. We're trying to incorporate those in the treatment of, for example, plasma cell leukemia. We're trying to incorporate those in high-risk myeloma. And SWOG has a very long-standing history of doing this in high risk, where they've been incorporating antibodies. And one of the first trials they did was actually bortezomib, lenalidomide, dexamethasone, and elotuzumab. With or without elotuzumab, that study did not show that there was an improvement in high-risk patients. But they have basically, SWOG has been trying to do this for like 10, 15 years. And there's been some improvement with daratumumab, but not to the extent that we would like. And so I think it's extremely important to get the cell therapies, and more specifically, the BiTEs in high risk disease as soon as we can.
Maybe I add I agree with what Elizabeth says, but I'm thinking I think it's important to also emphasize what is so-called high-risk disease. I think there is a huge misconception in the literature. And I think there's a huge misconception in the clinic every day in the whole world. So what am I talking about? Well, the current high-risk definition was developed about 15 years ago. And it was based on the following principle. There were clinical trials that enrolled patients that were newly diagnosed, and they were given the same therapy. And there were patients that unfortunately had relapse happening sooner than other patients. So the investigators went back and looked in the database to see what do those individuals have in common compared to the other patients. And they looked at the M spikes, they looked at the hemoglobin, they looked at the number of plasma cells in the bone marrow and all those things. And they couldn't really find anything, but then they saw that some of these translocations and deletions were more common in the group that had a sooner relapse. And then they said, if you have these changes, this is high-risk disease. Then the therapies continued to evolve, and better therapies became available. And for us, who spent a lot of time seeing patients in the clinic every day, all the time, what we have seen is that a lot of those patients who have these markers, if they're treated with modern therapy, they have the same prognosis as patients who don't have them. So if you had done this experiment one more time, you would not have found these markers. They would not be called high risk. They were based on weaker therapies. So I think you could think about it in different ways. You could say, if we continue to develop better and better therapies, there will not be any high risk anymore. That's probably true. We are not yet at that point, but if I think about many years ago, 30% or so of the patients would fall into the high risk group, and they would have a worse prognosis than the other 70%. But if I just treat and don't look at the markers, that group is probably 5 or 10% clinically. So it's a shrinking species of high-risk biology, if you want, or high-risk clinical trajectory. So that's very important to remember, that these are not written in stone rules. I have still patients who come to me and said, how could it be that I was diagnosed 10 years ago, I stopped therapy at my own discretion 5 years ago, I am still MRD negative, and I still have high risk? And I said, because you don't have high risk. But the doctor who first saw me at this or that institution said that. Yeah, but that was not right. And now you go back and you look in the chart and it says it was a 414 translocation. Yeah, but that doesn't matter. You do not have high-risk disease. So that's one thing. The other thing is that we also have learned a lot about the disease biology, integrating a lot of technologies. And Garrett Morgan, who gave the talk here on Zoom, he's a very close collaborator. He has spent a lot of time thinking about these things, same as we have. He published the first paper together with other collaborators showing that in patients who have a 17p deletion, which everyone says, oh, that's high-risk disease, that some patients also carry a mutation in the TP53 gene. So we all have 2 alleles for every chromosome, one from our mother and one from our father. And if one of them is deleted, that means that it's gone, that part. The other one, if that still works, that's good enough. But if there's a mutation in that one, that means that it's inactive. So for TP53, that's a tumor suppressor gene. That is a gene that protects us from cancers going bad. So if you delete 17p on one of the 2 alleles, that means that this gene potentially could be at risk for being turned off. But if you have the other allele intact, it won't happen. If you mutate it, then you don't have the protection of TP53. And I don't remember right now when I'm sitting here, but I think I read that elephants have is it 8 or 12 or something like that, TP53 genes. And I don't think elephants can develop cancer. Unfortunately, we only have one. So that's a weakness with the human species. So if you are both inactive, your biallelic inactivation, the prognosis is less good. But if you have only one knocked out with a deletion, you have actually the same prognosis as someone who do not have 17p deletion. When we look through our series with sequencing and FISH probes, we have found that around half of all patients with 17p deletion, half of them are mutant on the other allele and the other half are not. So in practical terms, what that means is that if you tell every patient who have a 17p deletion, you have a high risk, you lie half the time. That's the
Yeah, and
bottom
you're
line.
freaking people out.
At least you lie half the time. And I want to add something else there. So that's very important because I looked into this very carefully. In our paper, we based it. So when we looked at gene expression profiling, so the patients that were high risk by gene expression profiling, those are the ones that did but poorly. But you could have a deletion 17p and be low risk, and you would do fantastically well. And in fact, I have a patient who somebody wanted to do an allogeneic transplant. And I told them, there is no way you're doing allogeneic transplant on this guy. And this person got treated. Actually, he was from Florida. He's from Florida. And it was a long time ago. I mean, he's been my patient for a long time. But no, this person was treated and was on lenalidomide maintenance, decided he wanted to come off, and he's been in remission forever. I mean, you know, I only hear from him if there's trouble. So when there's like, hasn't been, I have saw him recently, but and so this is absolutely true. And it's something that worries me because the tests that we have right now to look at high risk are not great, the FISH test. And so we have to do sequencing. And so how do you get sequencing as a standard of care test that is going to be reimbursed? I mean, that's a whole other issue. But yeah, no, I agree with that. Yeah, go ahead.
Yeah, so sequencing is not yet standard of care, but this is going to happen, I would say, quite soon, hopefully. So one last thing I wanted to say about therapy, because the question you asked, Jenny, was how would you treat high risk? So I would like to be a little bit provocative and say, I would treat it the same way I treat standard of care. So what does that mean? The standard risk. So what does that mean? Well, if you take the best drugs you have, if you have a group that has a standard risk and you have a group that's high risk, who's going to benefit the most? It will be the standard risk group, right? And all the data shows that if you give your best therapy to that group, that's where you're going to see the best outcome. And you could then say for the high risk group, that's really where you want to give the best therapy you have. So who is not going to give your best therapy? Everyone is going to get it. The literature has been going back and forth, and there are some groups that have talked about risk adaptive treatment. So they look to see for these markers. And if you have standard risk, you got the not so good therapy. And if you have a high risk with these not so good tests, then you got the good therapy. So that makes no sense.
So this is very important. So the only thing we try to do, and I don't know if you do the same or not, we just prolong the best therapy. We give the best therapy to everybody. We don't do this thing. I don't believe in this thing that if you have the only hyperdiploidy, which is extra chromosome, that's supposed to be a good thing, that you would get less therapy. No. No, you get the best therapy. And then the patients that, that we think have high risk myeloma, then those just get really prolonged treatment with the best therapy that we have versus the other patients that we may give a little bit less of the therapy after they're in remission and everything. Because, it does have toxicities to continue therapy for patients that have high risk disease with 3 or 4 drugs. It has toxicity. So we don't want to do that unless we really have to. But yeah, we don't give less therapy for someone who has like good risk or something like that. We don't do that.
So I'll just add something really quickly because I know we took really long. But I mean, I think we definitely have to be careful. And in those true high risk or aggressive cases, if a treatment is not working too well, giving more of something that doesn't work, is not necessarily like the answer, right? So, I mean, it's like, if you're trying to use your hammer to nail, a nail in concrete and it's not going in, the answer is not a bigger hammer. I mean, you're still not going to get it in, right? So along those lines, I mean, I think both of you were alluding to this, is really a time when you need to think of alternative, therapies that use alternative methods of working. So like in this day and age, it's really the immunotherapies, so the bispecifics and the CAR T therapies. But it's definitely not, the answer is definitely not high dose melphalan. And I know in some places, but I think probably all three of us feel very strongly that like, for example, tandem transplants, high dose melphalan for the supposed aggressive disease. And as you guys say, it may not even be aggressive. Like, this is not the answer, in my opinion.
Today, I mean, over time, things have changed. Over time, things have changed. So I think everything has had a role or has a role, and things change because there are new options. And there will continue to be more and more options. And still, all the options are available, and they should always be viewed in the light of all the other new options. So it's a continuum of evolution here. That's how it is.
Mhm. Great, thank you so much. And I might save my last question I might have to sneak my last question in. I'll go to the other side of the table.
So, anybody have any questions? We've got a little bit of time left, and I've got a lot of online questions too. So, anybody in the room? Yes.
Thank you.
Oh, really?
For those of us like myself who are getting terrific and fantastic results from Revalid and Dara, but seeing a sinking of our heretofore red and white blood corpuscles and other immune systems, how worried should we be? And from a doctor's standpoint, is there a rule of thumb, or is it just each doctor's appetite for risk?
Be careful what you say. It's not yeah. Well, so the question here is how worried should you be if you have a modern therapy and you have a great response? I think that is a very modern therapy. There was a initial publication in the New England Journal of Medicine in 2019 showing how very effective that therapy is, and it gave FDA approval. And there was an updated publication in November of 2021 in the Lancet Oncology showing that when patients were followed for 5 years, the average patient still had no recurring disease. That's a pretty amazing result for this disease. I think I would not worry about anything, actually. I would just enjoy and think about good things, and also think about that there are so many new drugs coming. I mentioned that we expect the new bispecific coming in August of 2022, the first bispecific antibody. Looking online, I mentioned before, there are 4 more antibodies projected in the second quarter of 2023. And there are additional 3 in the back end of 2023. And there are many others that we and others are working on, or trispecifics or small molecules. I said when I started talking this morning, and I mean it, I think we are at the tipping point where there will be people diagnosed, there are people diagnosed with myeloma that will live the same lifespan as a person, the same age and gender without myeloma, with the difference being that there will have to be treatment given until we find a cure. So it's mostly an inconvenience and a toxicity issue with the drugs. Not every patient will unfortunately be able to benefit, but there will be many patients like this. I strongly think that's how it is. And when I was in med school, HIV was a very deadly disease. If you look in the statistics book now, individuals with HIV have the same lifespan as people, same age and gender without HIV. So there is no difference in overall survival. Myeloma is not exactly there, but there are individuals that will fit into that model. So I think the future looks very, very bright for myeloma patients.
So you're not concerned about the immune therapy dropping? I mean, the white, I mean, the immune system dropping, the white blood cells and
Well,
the red.
No,
blood
so we are trained specialists in blood diseases. We're hematologists, oncologists. So our training is to handle these types of situations, these diseases. These diseases are diseases of the immune system. Myeloma is an immune system cancer. So we are trained to do that. So we know for years that when counts go up and down, that's okay, because when we were done with the therapy, we know it will recover. So what we also know is that there are certain thresholds we don't like to go under. If we see it goes under certain numbers, we would either hold the therapy, we would reduce the therapy, the dose, or we would do other modifications. And if we need to do transfusions at some points with blood cells or platelets, or we can give growth factors for the white cells, we would do so. But the way we are giving these drugs is a very safe way, and we monitor all the variables and we take action. So no, I'm not worried about it. I'm really not. The future looks very bright for myeloma patients.
Are we getting any closer to CRISPR being used for myeloma?
And could you explain what CRISPR is?
Well, I'm not, it's been a while since
For
I've had to think
laypersons.
molecular biology,
Yeah.
but CRISPR is just basically a way, a more recent technology that allows really, really easy gene editing. And I'm sure there's more than one, but I know like it was I think my old college buddy is actually in the company now, is a PhD, but there's CRISPR Therapeutics, and they're working actually on an allogeneic CAR T. So that's like off the shelf CAR T where donors, just like blood, donors, give their cells. They are basically, they're engineered using CRISPR and can be given almost like a bispecific, meaning you don't have to like go through the regular CAR T process. I don't know if you-
I wasn't aware that, how far along is that developed?
Actually, I think they have it in ASCO.
They had?
There's like phase 1 data. I think it's about to be presented this ASCO.
Oh, it's going to be presented. Okay, because I haven't seen. So we have to wait for a couple of weeks for ASCO or a week for ASCO.
I have a couple of online questions, and raise your hand if you have. If a patient did not achieve MRD negativity after a stem cell transplant and not after consolidation, should that patient change treatment to try to get to zero?
I think that's a very good question. And I think the answer is, for the most part, no, because there are some individuals that will never become MRD negative. And if you follow them over time, and they are just like barely positive, they're same positive over time. I think we touched on this earlier today. If you plot this out over time, the prognosis is, if not identical, is very similar to someone who is MRD negative sustained over time. So it's all about the dynamics. So if it's negative, or it's just the same low positive over time, the clinical outcome is virtually identical. Different group is the group that turns negative and within that first year bounces back and becomes positive, and that could turn into progressive disease. And I also mentioned that although we can achieve MRD negativity in very many patients, I showed you some data earlier, over 70% for MRD negative. The remaining 29%, some of them were barely positive, but there is a very small group that had more disease left. So if there's more disease left, that means that this therapy didn't really do its job. Those patients, if you don't change the therapy, there will be a recurrence there as well. But I think there is no evidence that bombarding the disease, if it's positive, with more therapy till it becomes negative, that's clinically beneficial. The last thing I want to say is that having treated many patients and followed MRD status over time, if you treat for whatever number of cycles, the patient is MRD positive, you start maintenance therapy, you do consolidation or not, you start maintenance therapy, and a year later, around 30% or so of patients are MRD negative during that first year of maintenance therapy. It's just that it's a slower kind of achievement of it. And I don't have a molecular explanation. I've thought about it clinically as a little bit of a slower disease. And I've not found it to have any different prognostic direction. It's just behavior that's a little bit different.
I would agree, especially. I would agree, especially in newly diagnosed myeloma and in the early setting. I mean, I think we talked about this just yesterday, I think, Ola, but I think in some cases, maybe patients sort of internal thermostat or immune thermostat just get reset into more like an indolent MGUS like situation where they always have it, and the yin and the yang is kind of counterbalanced, and that's really the norm, the good norm for that individual patient.
Would you recommend CAR-T for a patient with extramedullary disease? And if you could briefly explain what extramedullary disease is.
So most myelomas, they are born in the bone marrow because that's where the plasma cells are. And as you know, the plasma cells come from basically stem cells and then B cells. They go to the lymph node, they get exposed to certain antigens from bacteria, from viruses, and then they change themselves into plasma cells that produce just a certain type of antibody. So we don't know what causes myeloma in terms of if there's a specific type of antigen that causes everything. There's some theories and some publications about some certain infectious viruses, for example, potentially being a cause of myeloma. But we really don't know for certain. Now, these cells, they go back, like the plasma cells, they go back to the bone marrow and they stay in the bone marrow, and they're very difficult to kill. They're very long-lived, and they just sit there and they produce the antibodies. So when they turn into cancer, they just sit in the bone marrow and produce antibodies. So what happens when these cells can exit the bone marrow, which is more, unusual in newly diagnosed myeloma, and, of course, doesn't happen in precursor disease, is that they can go to any other, really, they can go anywhere else in the body. But they have to be very aberrant, because the normal plasma cell, cannot survive outside of the bone marrow. It needs its niche and its microenvironment, and that's in equilibrium. And so when you have these plasma cells that are coming out of the bone marrow and they're going anywhere, they can, we see myeloma anywhere, in the lung, in the pancreas. I see myeloma in the stomach. I see myeloma, anywhere you can imagine, we see myeloma in the brain. So how does that happen? So these cells become so aberrant, they're able to live in another completely different environment. And so that's what we call the extramedullary disease. And so that's, you see, usually when you do a whole body scan, some type of, either a PET CT or an MRI, that's when you see these areas of disease. And then CAR-T has been seen to actually be very effective for extramedullary disease. So we have patients, I think we all have patients who have extramedullary disease, who've gotten CAR-T and who've had a really good response that has been sustained, at least a year or 2 years, sometimes even 3 years. So yes, if you have a patient, we have somebody has extramedullary disease and they're eligible for CAR-T, then that could be a good option for them.
I'm going to try to get 2 more questions in. First one's to Dr. Landgren, but for all of you. I'm excited about the slide Jenny alluded to with comparative PETs, but I'm not sure I understand. Was the more sensitive scan one that is available to myeloma patients, or is it only available in a trial?
So the slide I showed with a regular so-called FDG PET-CT, that is the standard of care PET-CT in any hospital around the world. That is based on labeled glucose. So the whole scientific idea behind a PET-CT, if a doctor orders a PET-CT, is that malignant cells eat more glucose than normal cells. That's the idea behind the PET-CT. So you can inject glucose and wait a little bit, goes in the body, goes in everywhere, and then you take the pictures. And if you see that there are areas that light up, those are cells that eat more sugar than the other cells. And the idea is that these are malignant cells. In multiple myeloma, the myeloma cells don't always eat as much glucose. They don't eat different amount of glucose than the background in every patient. In fact, if you do 100 patients with myeloma that have bone lesions, around 30 of them will look like there is nothing going on. So it's a false negative. So this is not a very good technology for myeloma. For lymphoma, which is a completely different type of diseases, usually those cells eat a lot of glucose. But for myeloma, it's different. But we all know how it goes. Something is discovered and then it's being implemented in every direction. So it was developed pretty much for other diseases, and then it became a myeloma test. So the antibody I show was labeling antibodies that bind to CD38, and CD38 is expressed on the myeloma cells. So we, in a nutshell, took about 1% of a single treatment dose, labeled them with something that you can find in the camera, injected these antibodies, and then saw if we could find them. So if they bound to myeloma cells, we could see them lighting up because they were programmed to light up for about a week. This was on a clinical trial. This is an open clinical trial that we have here in Miami. So it's not a standard of care. So that slide I showed on the left was an FDG PET-CT, the glucose one, the standard you have in every hospital. That was red negative. The same patient did 1 week later, enrolled on the trial, got this one dose of a very low amount of antibody. We took the picture and you saw on the right all these dots that light up. And we have biopsied these dots and we can see that there are myeloma cells in these dots. So it's a clinical trial. And it is open for enrollment, this study.
So we'll end on this one. Is it recommended that low risk or stable smoldering multiple myeloma patients retrieve their cells for autologous stem cell transplant?
Yeah. Then I can add something.
So I think outside of a clinical trial and well, I think the three of us would probably agree. If you have smoldering myeloma, clinical trial is actually the best option you have. And probably the worst option is to get treated off of a clinical trial, and observation alone is in the middle, depending on what the true risk of progressing to full-blown myeloma is. But if outside of receiving treatment, I don't think you need your stem cells harvested. That's what I would say.
I would agree. The recommendation for collecting your stem cells when you're being treated and you have a smoldering myeloma comes from the fact that most of the studies that patients are being treated on give lenalidomide. And lenalidomide has been associated in newly diagnosed myeloma with having lower yield of collection of the stem cells. So we are extrapolating, knowing that lenalidomide can decrease the collection of your stem cells when you are newly diagnosed myeloma. We're extrapolating that if you're a smoldering myeloma and you are going to get on a trial where you're going to get lenalidomide for forever, until you basically relapse or you stop it because you have toxicities, or you're going to get it for 3 years, then, potentially you should collect stem cells. Now, the issue with the stem cell collection in smoldering patients is that it may take longer for you to reach a really good response. So if you do, 6 cycles or 6 months of lenalidomide or lenalidomide with dexamethasone, and that's on a trial, then you want to collect your stem cells as soon as you have some sort of remission. You don't want to collect your stem cells when your M protein was 2.6 and now it's 2, because you still probably have a lot of disease in the bone marrow. You may want to just wait until at least you have partial response or a very good partial response. So you have a decrease in the burden of myeloma in the bone marrow. And so some of these treatments that are in the smoldering myeloma world, they may not get you to a partial response in 6 months or in 4 months. So you may need to do a treatment a little bit longer. In my experience with the drugs that we have right now to collect stem cells. I have not had any patient having any trouble collecting stem cells after being treated for smoldering myeloma, even when they've been treated for more of a prolonged period of time. So I would say that you have to talk to your doctor when would be the best time for you to do the collection if you have a smoldering myeloma and you're on treatment.